Good evening, and thank you for joining EP Lab Digest for tonight's Roundtable webinar. I want to thank BioSig Technologies as well for supporting this evening's educational event. If you have questions to ask, we do encourage you to post at any time during this event utilizing the live chat feature, and there will be a Q&A at the end of the roundtable. Now, without further ado, I'd like to hand over the webinar to Dr. Natale, who is the principal investigator of the Pure EP 2.0 study. Have a wonderful evening.
Good evening. This is Andrea Natale from Austin, Texas. So I have the pleasure to introduce you with the panel that we have tonight to discuss the Pure EP study. Dr. Amin Al-Ahmad that work with us in Austin, and Dr. Wendy Tzou from University of Colorado. Wendy was one of the blind reviewer in the study, and Amin is the first author of the paper that just came out in the JCE, in the Journal of Cardiovascular Electrophysiology. So let's start with Amin. Amin, why don't you describe the current limitation and challenges in signal acquisition for the EP lab that the Pure EP technology has been designed to address?
So thank you, Andrea. It's a delight to be here. I'd like to address first some of the limitations in the EP lab. So when we think about the EP lab, this is kind of a cartoon of what the EP lab looks like. You'll have a patient on the table, but importantly on that patient, there's a lot of connections. So we have everything from an ECG connection to an infusion pump, a pulse ox, you'll have the defibrillator pads on, you'll have a mapping system, an electroanatomical mapping system, whatever the data acquisition system, ablation generator, if you're placing an intracardiac echo, all of these things are connected to electricity. Sometimes they're plugged in different plugs, and depending upon how that EP lab is grounded and depending upon all of the things that are surrounding the patient, you generate some significant electrical field and some significant electrical noise. And all of these things can impact our ability to detect the biological electrical signals that we need to detect in order to perform a good EP study and a good ablation. EP labs are generally grounded, as you can see, but even with that grounding, you'll have a lot of these external sources of noise. So when we think about how a signal is delivered to us, when the catheter tip touches the tissue to when we actually are able to display that signal, a conventional acquisition system typically goes through multiple steps, and these steps include things like instrumentation amplifier, variable gain amplifiers. There's, of course, the high-pass filter, the low-pass filter, the Notch filter, another amplifier, and then an A to D or analog to digital converter. And the problem with all of this massaging of the signal is that you lose some of the signal fidelity. And what you end up with is a low signal-to-noise ratio, and some information becomes lost and is really not recoverable. In addition, you can get some ringing effect with all of these filters that can create noise or create signal when it doesn't exist, and that can sometimes fool you. So it's different in the Pure EP signal. The system is it's a very novel setup that typically takes from the catheter the signal and does something called signal preconditioning, utilizes a fixed gain, and then transforms it to a digital signal for us to display. Now, the advantage of how they do things differently and how they don't end up overly massaging the signal is that you end up with a high signal to noise ratio. So you can end up seeing the quality of the signal a lot better and eliminate all of the noise that you have. So the raw information without loss of information is sent to the digital display, and that allows us to make judgments in terms of what's useful and what's not.
So let's go back to Wendy, and thank you, Amin, for the explanation. So Wendy, why don't you go over some of the methods, and especially considering you were one of the blind reviewers, why it's so important to look at this data in a blinded fashion?
Yeah, I think if you want a fair assessment of signal quality in a comparative fashion, you have to minimize bias as much as possible. And I think that's why the blinding was so important. So this was a prospective multicenter study that involved 3 hospitals within the United States. There were 51 patients who were undergoing cardiac ablation procedures in the procedural mix that is shown on the right there. The majority were patients who were undergoing ablation for persistent atrial fibrillation, followed closely by patients who are undergoing ablation for VT or PVCs, and then atrial flutter, and then paroxysmal atrial fibrillation. There were a total of 235 data sets that were collected and then analyzed, and then 3 independent blinded EP reviewers, myself being one of them, looked head-to-head at the signals within the pure EP system compared to those obtained from the standard conventional recording system. So the study results, I guess I should go through first the review of data sets and randomization and the process, the flow diagram of how this all occurred. So the data was all acquired, a core lab reviewed all of the data, and there were 108 sample sets that were reviewed with 182 individual noted annotated signals of interest that were identified. And a number of sample sets failed the quality review at this stage before then progressing to the next step, which was the first randomization. So there were 101 pure EP samples that were randomized to either mapping or recording system sample to create a pair. And then following this sort of randomization process, another 9 specifically sample sets were identified that didn't quite meet the quality metric and then were removed from further analysis. And then after that first randomization process was completed, there was a final review by the principal investigator, Dr. Al-Ahmad, and additional edits were made before then proceeding to randomization step number 2, which was really the final randomization step before the reviewers, the blinded reviewers, then were able to analyze the data that were collected. The core lab signal categories that the reviewers, the blinded reviewers, were kind of focused towards comparing were color-coded. So there were various signal categories by colors you can see there. So overall signal quality was a question that was assessed amongst all of the samples. And then following that, amongst a number of them, we were asked to look to distinguish whether or not there were differences between small or fractionated signals of clinical interest, whether or not the one mapping system versus the other was better at distinguishing near field versus far field signals, and then whether or not there was a difference with respect to recovery of signals that could be observed after a significant change, be it pacing maneuver or cardioversion. And then finally, quality of ablation signals that were observed during RF ablation delivery.
Thank you, Wendy. So let's go back to Amin. Amin, now that we have a good idea of the method, why don't you guide us through the study finding and comment on which are the clinical implications of the results of the study?
Thank you, Andrea, and thank you, Wendy. So when we look at the study findings, you can kind of see in this table here, on the left, you see that there was 92 individual signal sets, and that generated 235 questions that went to the reviewers. Now, how it was graded was if 2 or more negative reviews, it was considered inferior. If 2 or more ratings, said it was equivalent, it was considered equivalent. Or 2 or more positive ratings, it was considered superior. So you had to be, good enough to be superior or equivalent, but by 2 people. 2 people had to rate it as better. Now, what was interesting to me was that there was consensus, meaning all 3 reviewers agreed 40% of the time, which is kind of interesting because when can you actually get 3 EPs to agree on anything 40% of the time? And majority, meaning 2 out of 3 agreed 52% of the time, and only non-consensus 7% of the time. And then if you look at the different categories in this last box, you'll see small to fractionated signals of interest. And if you just walk down that category, you'll see that the majority of those were either superior or equivalent. And I'll show you the actual percentages in a little bit. Ability to discern near field from far field, the majority were superior or equivalent. Recovery from pacing or cardioversion, the numbers are small, but again, majority superior or equivalent. And ability to interpret the signals during RF delivery, majority were significant, were superior. And lastly, overall quality, the majority were superior. So again, 93% consensus, and for the most part, about 75% were rated as superior in this particular data set. This is a sort of graphical way to look at this. And in this particular graph, we're looking at overall quality, and we're looking at near field versus far field. And the reason we're looking at these is because that's where the numbers are. The other ones are smaller numbers. But you can see here that the majority are either superior or equivalent. So when you look at overall quality, near field versus far field, ability to discern between them, or look at small fractionated signals, all of them statistically significant, and all of them clearly either superior or equivalent, with a very small number, less than 10%, being considered inferior. So in terms of what this means clinically for us, or what this means for us, is one, a very high consensus amongst EP reviewers, and then two, again, like I said, about 75% improvement in signal quality. And the clinical relevance of this is really enhanced ability to detect the difference between small signals. Are they near field? Are they far field signals? And also small fractionated potentials that are potentially important as targets for ablation. At least 73% of the time we can distinguish those better with pure EP, and 83% of the time we can distinguish better with pure EP near field versus far field.
Thank you, Amin. Let's go back to Wendy. Wendy, I'm sure that the viewer are interested in trying to understand what is the clinical utility of having better signals, and how being able to detect physiologic information that otherwise are lost with the current recording system can make a difference. So would you mind to share some example and give your perspective of how pure EP can make a difference during cases?
Sure. Thank you. So I think, we're electrophysiologists because we are not, we're not interested in just targeting something anatomically. We really want to understand the physiology of what we're doing, and being able to see signals clearly, electrograms clearly, is critical in sort of that effort. And so this is an example of a comparative tracings. And if you look at the ablation channel signals highlighted in yellow there, you can see that in this 76-year-old man who has persistent atrial fibrillation, who has subsequently been converted to sinus rhythm, that with ablation, you see that there's less noise on the distal ablation signal compared to, as well as sharper near field signals on the lasso channel, highlighted in orange there, compared to the conventional recording system. Why is this important? Well, especially in an age where we are trying to perform AF ablation more efficiently, we are frequently sort of ablating and moving the ablation catheter while ablating. And we want to make sure that where we're moving it to is a place of relevance, in order to avoid excessive ablation. And so being able to see signals clearly while we are ablating, and especially when we're using another mapping catheter within an area of interest to guide where we are to ablate, being able to see those signals well and not have the signals obscured by artifact from, the RF generator is critical. So this is a nice example showing that difference in both the ablation catheter as well as the mapping catheter. This is another example from a 66-year-old man who has PVCs. And you can see in the boxes highlighted in both orange and yellow. So this, you can see from the surface, it looks like an outflow tract type of PVC to the far left there. But where the ablation catheter is located on the right, using the conventional mapping system, you don't really see a very, it looks like first of all, it's not that sharp of a signal, both near field and far field. You see a very early sort of signal that's on the ablation catheter with the PVC that is also present in sinus rhythm, which is more apparently, when you look at the pure EP system, consistent with a His signal. So clearly an area that you would not want to ablate. And that's kind of demonstrated nicely here. Another example here, this is a 72-year-old woman who has non-ischemic ventricular tachycardia. Ablation channels here again show sharper and larger near-field signals on the pure EP system compared to the conventional GE Cardiolab system. And I think just delineate more clearly in each of these cases where a better ablation site would be delivered. This is a demonstration of concomitant CS pacing. And then you can see here a clear visualization of the fractionated atrial potentials on the ablation distal compared to, as well as CS signal visualization after the pacing stimulus has been delivered. You can see it so differently on the pure EP system. You can see how sharp and near field these signals look on the ablation distal catheter, as well as on the CS where the pacing stimulus is being delivered, compared to on the conventional mapping system where there's clear oversaturation that then hides, the clarity of the signal. This is an example of termination of an atrial tachycardia, which shows additional signal components on the pure EP system, both in the ablation distal as well as the crista channels during ablation, as well as then with subsequent completion of a line of block. This is, I think, a really nice example of the difference in the clarity of signals. This is an 82-year-old man who has a prior AF ablation and then subsequently developed persistent atypical flutter. So in your mind, of course, you're thinking that there's some reconnection somewhere, and we're looking for some area that reconnection has occurred that we should target. On the conventional mapping system, you see no sign in this area where the ablation catheter is positioned at the exact location, where on the pure EP system with a digital zoom kind of feature that is enabled, that does not over process signals, as Dr. Al-Ahmad has explained, that you have this very long duration mid diastolic type signal that is certainly of great importance that would otherwise have been missed on the conventional mapping system. This is an example of a 68-year-old man with a history of prior MI. And you can see that during VT, you have a mid-diastolic potential on the pure EP that is seen on this distal CS recording during VT. But on the subsequent same catheters, but using a conventional mapping system, you do not see that mid-diastolic potential nearly so clearly. This is another VT case, in this case, a patient with ischemic cardiomyopathy. You see this mid-diastolic potential during VT on the recording system. And it's unfortunate we don't have a comparative example from the conventional mapping system kind of view. But what you can see here is a mid-diastolic potential. Looks kind of big, but it's kind of rounded and looks actually a little bit far field. And in fact, ablation at this site endocardially led to slowing of the tachycardia, but then subsequently sort of pushed the exit more epicardially, which you can kind of see clues of on the surface ECG there with the slowing of the tachycardia occurring.
Very good, Wendy. Thank you. So, Amin, now in Austin, we've been using the system for about 2 years. How do you sort of integrate sort of the advanced signal information that we get from the system in your clinical workflow?
Yeah, so the easiest thing we do is actually display it. I mean, it's there, it's easy to display. And as was alluded to earlier, the study compared conventional, which both included the standard recording system, but also the mapping system that we use. So we're able to display it as part of one of our screens. And so if you look in this slide, in the center, top center, that's the pure EP display. And that can be displayed next to your Pruka In this case, it's above the CARTO signal. So you do have the ability to display things, to zoom in on things just by putting it there. And so it's been very useful, because what we can do is, for example, if there's a signal that we're not sure of, we're able to potentially zoom in, or we're able to look at it in the different systems and just confirm, is it real, is it not real? Do I have block? Do I have isolation? Things like that. So that's been pretty useful. Another thing, this is from a different center. They adopted a workflow where what they'll do is they'll see something on the ablation signal, for example, where there's an area of interest, and they'll tag that on their electroanatomical mapping system, simply because they're not able to see it on their mapping system signal with the ablation catheter. So from that perspective, it's also useful that you can tag areas of interest as you're potentially roving around with the ablation catheter in different areas. There's different ways to integrate pure EP into the work, your workflow.
Very good. Thank you to both of you. I think you've seen some very nice example of cases where the system clearly make a huge difference with recording. Sometimes the signal are better, just sharper. So not necessarily a sort of an enormous difference, but clearly in some case, you can really miss information that are very, very relevant to make the decision during the case. So clearly this is something that we have sort of been waiting for a long time, and I think we're very excited to be part of this project. So before we go to the Q&A, both Amin and Wendy, what are the impact of advanced signal processing on the future of electrophysiology? Why don't you give us your thought on this issue? Maybe Wendy, why don't you start?
Sure. Well, I think from the most basic level, being able to, especially as we progress to doing more complex procedures, being able to really distinguish signals that are of importance to target versus noise or distractors is critical. We've gotten very comfortable with ablating more, but I think we could get better at ablating smarter, and a system that helps us to do that, I think, is important moving forward.
So I think a couple of the things that, for example, when we do mapping now, we're doing high density maps with multiple electrodes. So we'll have a multi-electrode catheter, and we'll wave it around the chamber of interest. And that collects a lot of data, but it doesn't ensure that it collects a lot of good data. So I think that, trying to figure out how to incorporate better electrogram data to make us more accurate maps would be potentially interesting. There's a couple of things here that I think are potentially kind of future and maybe, for example, is there a way where we can detect changes using the electrograms that might allude to better ablation or higher quality ablation? And is there an ability to use machine learning somehow to aid in our advancement in terms of delivering therapy? So I think there's a lot of open concepts and things that for the field to move forward. It's refreshing to see that there's finally been some innovation in the recording system, which there has not been for a very long time.
I think too, if there were some way in which, because we all know that the high density maps in particular that are created can be very pretty looking, but they often require a lot of manual processing. So if there were a way in which a system could be implemented with existing mapping systems to make more automation possible and less kind of manual manipulation, because you can really change how a map looks following acquisition of data. And that can either be for the better or for the worse. And so some way, again, if there were machine learning or artificial intelligence ways in which to make that more possible, it would definitely streamline the process. And in particular, kind of as we're dealing more in 3 dimensions, with respect to mapping arrhythmias, ventricular as well as atrial, the ability to distinguish between what is what and to know when we have to do or implement more advanced or adjunctive ablation strategies would be critical.
Another area, that we discuss, especially now that we're using more and more electroporation, is if we can find through a better signal processing indicator that the lesion has been sort of permanently effective. We all have, we already have done some cases of recurrence where we've seen reconnection despite the acute effect was spectacular. So if we can find the indicator that actually those lesions are actually permanently effective, I think that would be another potential advantage of a system that give you better quality of signals.
Yeah, durability, I agree.
Okay, so maybe we'll now transition to the Q&A. Okay, good evening. So again, we are. Good evening. This is Andrea Natale from Austin. We are back live with the Q&A session. And I have the pleasure again to have Dr. Amin Al-Ahmad and Dr. Wendy Tzou. So I'm going to start with some questions that came through. One of them is about additional studies that are ongoing. And we just finished a pilot REDO AF study. And one of our, the physician in our group just went through the revision of the tracing in a blind fashion. We are also in the process of starting, we'll talk a little bit later, several projects in artificial intelligence with the Technion University in Israel, and we had discussion about the economics of having a sort of a more accurate recording system. So I have a question for Amin, and also obviously Wendy, if you want to chime in. During the study, was the filter setting control between both systems or not?
Yeah, well, the filter setting in the study was really left up to the operator to optimize on both ends. So we asked the operators to give us the optimal setting for whatever recording system they were using, and then we used the optimal setting on the Pure system. The reason is they're not exactly transferable in that the average recording system will have a lot of different filters, notch filters, bandpass, this and that, whereas Pure is a little bit simpler to set up. So it's a different way to think about things, but both were optimized as much as possible.
I want to ask a question to Wendy. Wendy, in which type of procedure do you feel that the system would have most value? And in the study that we just published, where you were one of the blind reviewers, were there any accessory pathway?
That's a good question. Honestly, I can't think of a specific example in which I think it would be most advantageous, other than in the setting in which signal clarity is the most important. So that would include most of the types of ablations that were included in the study, which were AFib ablations, VT ablations, typical, atypical flutter. And specific to the AFib ablations, I would say that it's primarily after you've attempted first pass isolation of whatever you're trying to isolate, and you're trying to see if there are residual gaps. That's my impression of how it would be really, really useful in those cases. And having just done a procedure like this week where we hunted around for residual, probably transmural epicardial connection signals, and how much more time it added. Having the ability to very quickly assess where gaps are, to streamline the workflow and time that these types of cases take would be tremendously useful, especially when we're really focused on trying to increase throughput through the lab, increase lab efficiency in order to help to take care of more patients. With respect to the accessory pathway group, I think that there were a few that were included, but it was a small number in comparison to the other types that I mentioned. I think that would also be a very useful way in which to kind of target and hone in on, where to ablate focally. What ends up happening, I think, more often than not is, unless you have crisp, clear signals, there does tend to be a little bit more than just spot ablation to eliminate many pathways. And I think that this would help to facilitate that.
I mean, can you, in the presentation, the webinar, we talk about how filtering with the conventional system affect what we see. Can you expand on that issue?
Yeah. So part of the problem, and we're starting to realize this, has actually been some publications about this a long time ago that kind of were forgotten, and now that there's been renewed interest in acquiring good signals, you start to realize that every time you add a filter, you add the potential to create new problems. For example, one problem is ringing. So you can actually see what's called ringing artifact on your signal. And it looks like high frequency stuff, but it's not physiologic. And so it's the kind of stuff that we're tuned into looking for, but we could be fooled by looking at it. And it's because you've over-filtered or because of the filter settings that you have. So I think that's one area where not having the typical type of filter is helpful.
To both of you, do you think that this system can add value to left bundle and his bundle pacing procedures?
Well, I think that it potentially could. His bundle pacing seems to be falling a little bit out of favor, but certainly this left bundle area pacing is really has taken off, and the ability to better identify an ideal spot to place a lead that would have very good parameters, as well as encourage, kind of more conduction system pacing, and to do it in a way that increases the speed of the procedure, I think is ideal. And, I think the way that a lot of people, myself included, currently do the left bundle area pacing lead deployment is roughly anatomic. So if we could refine that better, because we don't always end up with a particularly narrow QRS that way. So if we could find a way to identify signals that would point towards better places to place a lead such as that, I think it would be ideal. I think there may already be some experience in doing this, but maybe Amin knows more about that.
Yeah, I've not had any experience personally. Maybe other folks have, but I think that, in particular, as you're putting the lead in the left bundle area, for example, as you're screwing it in, you're checking your signal and looking for different signal characteristics. I think anything that adds to our ability to define that and understand that better and save time potentially, so that you're not screwing in and unscrewing or accepting something that's not quite as good as you'd like. So I think there is definitely room for research and room for improvement there.
And I believe, we haven't done any case here, but I believe that they are collecting cases in a center in Boston where they've done probably already 10 or 15 cases. Yeah, so we'll see the data from that. One of the questions, actually I wasn't aware that there was a press release about our collaboration with the Technion University about artificial intelligence project with BioSign. And so they asked about the long-term objective. We are planning several studies. The main theme is to predict with the ECG and intracardiac recurrence, so that you can sort of eventually from the get-go know this is a patient where PV only doesn't work, you have to do more. So we're trying to kind of look at those parameters by using artificial intelligence. combining both the ECG and the intracardiac of the cases at the beginning. So that would be interesting if we can do that, because that would be a valuable information to an operator to know, from the beginning, this is don't stop at the pulmonary vein, do something else.
And I wanted to add too, I think that's very exciting, not only for the immediate implications for procedural efficacy and strategy, but if they could somehow then use that information coupled with the ECG information to then better refine who might go on, who could we predict in clinic based on their sinus rhythm EKG might go on to have AFib, and be more proactive about following those patients. I think the potential there is tremendous.
They were asking when was the first system installed. It was in November 2019, was in our lab. And then when they are asking about if the result based on the procedure type were the same. And if I remember, they were senior, but if maybe Wendy or Amin want to elaborate on that.
I can say a couple of words. The results were really across all of the different procedure types, but as most labs, the most common procedure we do is AFib, and so that was probably most represented procedure in there. But really, it was consistent across all of the different things that we looked at, consistently better.
One question is what is the addressable market for this technology over the next few years? So obviously, it's any EP lab that is interested in better signal quality. So it would be huge. Obviously, scalable based on the ability of the company to produce those systems. But I think any EP lab would be a potential site. What about this technology impact on PFA? Do you want to, any of you, comment?
I think it's going to have an impact. I think that, look, PFA is in the beginning of the road. We've done some PFA procedures. It's definitely impressive, but we're still learning a lot about it. Things like how important contact is, and when there's recurrence, what we're finding, and things like that. So I think it's naive to think that we've sort of figured out everything there is to figure out about PFA. So I think we need to think about PFA like we've thought about other things. And yeah, signals are important with PFA, like contact is important. So all these things are going to matter for PFA as well.
And actually, to expand on that, one of the artificial intelligence projects that we discuss is to predict when we've done enough with PFA, when those lesions are durable. Right now, every company has a different recipe, number of applications on the same location. But we were discussing exploring a predictor of permanent lesion because the acute effect across the board is very impressive. But we've seen some recurrence. So when what we have done acutely is enough, I think will be important eventually.
And I think too, if you could, if somehow the system is able to enhance signals consistent with areas that might reconnect, later, that would be very valuable.
Very valuable, yeah. They're asking if there is any advanced signal data training required for physician.
I don't think so. I think that what you'll find is that there's signals there that you didn't think existed, which is kind of cool because you look at the standard recording system and you say, oh, it looks like everything's done, it looks fine, but then you look at the Pure and you go, oh boy, there's a little sharp thing, or there's a prolonged, and you saw the examples in the presentation, there's things that you can see that you wouldn't see before. I don't think it takes more training. It's just kind of an eye-opener, to be honest.
Yeah. I don't see the need for training because it's just assessing signals and sort of getting more information. Another question is if the Pure EP perform differently depending on the mapping system, and the answer is no. Yeah, it's a recording system, so doesn't change based on the mapping system. One question is, does the Pure EP what is the difference between the existing system? Because I think we talk about, Amin mentioned that at the beginning of the webinar. What is the, if you can expand on the analog to digital processing between pure EP and the other existing system, especially, I guess, Pruka is the most commonly used in US.
I don't think I know enough about that. I can tell you that they go analog to digital at different phases in signal analysis, but the actual recipe of how they go A to D, I'm not entirely sure. So I don't know. I don't know the answer to that one.
What I can tell you is that we look at the amount of information that are filtered by the conventional system by superior P, and there is a significant amount of that happening. So that's something we actually tested. So it's really about trying to limit the amount of filtering that become, I think, even more become more relevant with the small amplitude recording. But we look at that on a bench, and it was pretty impressive, the difference between the conventional system and PRP. Somebody is asking, do you believe this technology can make ablation procedure more effective and efficient?
I think the potential for it to do so definitely exists. I mean, kind of alluded to this earlier, but if you can speed the efficiency with which you identify areas that really need to be targeted with respect to ablation, and you end up speeding up the procedure and improving the efficacy as well, because you're actually ablating something that's relevant, then yes, I think on a mass scale, when you add all the cases together, then yes, there is that potential.
Somebody can say, are there other companies building similar technology?
I'm not aware of anybody else who has anything like this. And that's kind of the interesting thing, is that if you look at our field, there's not much that's been done with our ability to look at signals until this. And it's interesting because our field is really all about signals. And so it's kind of refreshing that there is this technology available now.
I think there is a recording system that has been tested in Europe, but to be honest, I don't know the specific of the difference between pure EP. So obviously, I think one thing that happened in this war is that nobody, as Amin mentioned, has been doing anything to improve the recording for decades, despite we've been complaining. I think now the pure EP is out there. I've seen some motion. So it's going to prompt some, competition for sure, as it happened all the time in our business. So do you think that this is going to become the standard of care eventually?
I think, like Wendy mentioned, the pressures for us are to increase efficiency, increase efficacy, do a better job with our ablation. The technology is getting there. So I think when you all put it together, it makes sense that it could potentially become standard of care. And I think that I also give them credit that they're doing the science behind it. We're doing studies to examine the value and examine where it fits in clinically. So I think that's important too.
Yeah, I totally agree about that. I mean, this is not an easy way to look at this type of information. I think they've done a great job in sort of being open with us and designing study that can give some idea of the benefit. So I totally agree. I think we are done with the question. So I want to thank, obviously, Amin and Wendy for being available this late at night, and for everybody that was online to listen to us, and obviously, to Pure EP that supported this program. So thank you to both of you, and thank you to everybody that is online. Good night.
Thank you. Good night.
Bye, good night.